So our next panel leads very nicely. I see our speakers. It's going to be led by Dr. Bob McNillis, who is the Senior Advisor for Primary Care at the Agency for Healthcare Research and Quality. In that panel will be Dr. Jonathan Tobin, who is the President and CEO of the Clinical Director Networks Incorporated, and also Dr. John Heinzman, who is the investigator out of Ocean, who is Oregon PBRN Network. And the last, not the least, is Fred Rockman, who is the CEO of the Alliance in Chicago. And this panel is supposed to talk about the values of PBRN network. And Dr. McNillis, if you could so kindly lead us off, please.
Great, thank you very much. Let me just do a quick check. You guys can hear me okay?
Yes.
I'm on a slightly different device than I expected this morning. As you can imagine, government computers can be temperamental sometimes. But great to be with you all. Thanks for the introduction. I want to give a special thanks to Anne and Oliver for putting this panel together. We've had some great conversations over the last few weeks, and I think it'll continue today. I've got a few slides. I know I really appreciated Sharif's and Andy's presentations. They were just terrific. Andy in particular, I liked the way that you're thinking about primary care at the Center of Work as Senior Advisor for Primary Care at AHRQ. That's the way I think about things too. Just to reiterate, I'm Bob McNillis, and I am from the Agency for Healthcare Research and Quality. So I am a sort of government employee. Happy to be here today to moderate the panel. Really, it's a star-studded cast, I think, really talk about the value of practice-based research. I'm going to provide a brief perspective on PBRNs from the AHRQ perspective, and then really look to the panel for their reflections. Please send in your questions along the way. Throw them in the chat. We'll be keeping an eye on the chat. We'll have lots of time at the end for questions. So if we go to the next slide, Oliver, this is just a quick, the two objectives for this particular session. I have to put in a disclaimer that this is just me. This is not the government talking. I don't have any financial relationships to disclose. I don't think the panel does either. I remember when I did, and I wish I did, but no. And then next slide, Oliver. This is who we are. We'll be going in this order, and you can see we've got some great folks to provide their reflections today. So next slide, and this will just dive right in. For those of you who don't know, the Agency for Healthcare Research and Quality, our mission is really to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable. But the second part of our mission is really to work with the Department of HHS, which includes partners like the Centers for Disease Control and FDA and NIH, and other partners like you to make sure that evidence is understood and used. And I underlined some of the main points, I think, from our mission statement, but actually what I really should have highlighted is evidence. Evidence is the key part of what we do. We are the evidence agency, and trying to generate evidence and then get that evidence into practice is crucial for AHRQ, and that's where PBRNs come in. Go to the next slide, Oliver. This is really a question that was really part of a title of an article that Larry Green wrote back in 2008 about changing the way we think about research. And this was subtitled, if it's an evidence-based practice, where's the practice-based evidence? And we've often used this, I often use this as, in order to do evidence-based practice, we need practice-based evidence. And where is that practice-based evidence going to come from? And hopefully that answer will become self-evident as we move through the rest of this, the conversation this morning. If you go to the next slide. So here's some information that we've collected about PBRNs. AHRQ maintains a national registry of PBRNs across the country, actually around the world. We currently have about 169 PBRNs in that registry in 37 states, although I think practices represent every state. We actually have about a dozen international PBRNs as well in that registry. So we try to keep track of where they are. People try to connect through our registry and others. And we actually have a definition of PBRNs here, groups of primary care clinicians and practices working together to answer community-based healthcare questions and translate research findings into practice, which is very consistent with what we've heard today. Interestingly, you also had a definition I noticed on the materials that Anne and Oliver had sent out that I think works very well also about how to bring clinicians together to answer questions that are important to the community. That is also there. But there's one other definition that I found in one of our earliest funding announcements, and it was about an organization that comes together that transcends a single research question or a single research project. It's about a group of people focused on a collection of research to try to understand what those key answers that need to be found to provide the best healthcare within their community. So you go to the next slide. So here's a bit of ARC's background. Many of you may already know that we have tried to fund practice-based research networks over the 30 years of ARC's existence. Dating back to 1990, we had some of the earliest support for PBRNs. At some point, we actually funded about $10 million to the early development, infrastructure development of practice-based research networks. Back in the 90s, $10 million was a good chunk of money. Well, it's still a good chunk of money now, but that was pretty significant things to get things off the ground. And then the 2000s, we actually started funding more capacity building, funded some new PBRNs to do some planning grants, to create new networks. We actually began to convene the first annual PBRN meeting that continues today. Despite COVID, the PBRN community has still been able to have an annual meeting every year, which has been terrific. Then we funded some PBRN small research grants and translating research into practice awards. And then most recently, we have supported expanding collaborations through support of Centers for Practice-Based Research and Learning, what we call the P30s. Let me talk about each of these phases in the development, because in some ways, these three eras of ARC's PBRN funding are also sort of the natural history of how a PBRN develops. It starts with building the infrastructure and then creates more capacity and then expands its collaborations over time. So there's a bit of a model here for how PBRNs might develop over time. So if you go to the next slide, Oliver. These are just some examples from these earliest funded projects that we had in the 1990s. And there's two things in this slide that I think are interesting. One is, what was the topic? And two was, what was the PBRN? Some of which are still around today, and some of which have moved on to other things. So child abuse reporting, telephone care for Medicare patients, an international study of acute otitis media that was done by Aspen, one of the earliest PBRNs. Thinking about ambulatory medical errors and virtual medical error reporting system. This was 90s, sort of pre to err is human from the IOM. Thinking about use of EMRs in the 90s as indicators of medical error. So you can see some themes here in some of the earliest things. And partly safety and quality is an important focus for AHRQ. And we also focused on pediatric care. And I shouldn't talk about low back pain, since that got us into trouble once upon a time many moons ago. But we'll go ahead and move on to the next slide, Oliver. And in the capacity building and that set of grants in the second era of funding, the questions got a little bit more sophisticated even, I think. It's really around redesigning care and how to implement care into practice. So you can see we went from building an infrastructure about answering some common questions or important questions around care to actually think about, okay, how do we implement some of this information into care? And can we understand what some of the best ways to implement some of these findings into practice are, whether it's redesigning primary care around asthma or thinking about different mechanisms for getting immunizations done. You can see a wide range of questions. And then if we go to the third era, here's an example. If you go to the next one, these 8 nice little logos or graphics really were the 8 P30s that we funded. And I know our panel today, all of them were involved, and I think all you guys were involved in the N2, I believe, network, which I'd love to hear more about. But this was a way to bring PBRNs together, so networks of networks to answer big questions and do important projects to support PBRNs. Then if you go to the next slide. So really, actually, I think we're on the verge of really the fourth era of PBRNs now. There has been a lot coming out of AHRQ. The first paper on the left there was really a congressionally mandated study done by the RAND Corporation about health services and primary care. And it was looking for how all the different government agencies in particular coordinate and fund research around health services and primary care. And it really indicated that AHRQ is the place where primary care research should live, and coordinate that research with research being done in other agencies and other specialties. So really that was, I think, an important indicator for what our future looks like about how we coordinate our work across other federal agencies. The second paper there is really one that doesn't yet exist, but it's one that I hope to produce soon, based on a December meeting we had where we brought together people to think about primary care research and coming up with an agenda for the 2020s and what to focus on there. And just to let you know that PBRNs were an important part of the research agenda that we're going to have for the next decade. And then lastly, just last month, the National Academy for Science, Engineering, Medicine released a report on implementing high quality primary care that really builds on a report they wrote 25 years ago. And it really about how do we redesign primary care to really put it, as Andy said, at the center of healthcare, at the center of health. And there's some important indications in here about what ARC should do related to research. And also here, I think PBRNs are going to be an important part of that. Next slide, please. Well, once upon a time, and this was actually thank you to Jonathan Tobin who suggested I include this slide. We did I did a talk at the PBRN meeting about some of the things that I had heard just at that meeting, walking around, listening to talks about what were some of the big questions of value for PBRNs. And these are some of the many different things that folks came up with. Really this question about big data versus small data, and I think sort of almost narrative medicine versus how you use large data sets, about how you break down the walls. And little did we know back in 2017 that practices without walls and virtual consultations was going to be the norm for 2020 as we moved into an era of telehealth. Thinking about health equity, how do we train the next generation? How do we make sure patients are at the center of what we do and that the communities are engaged in the work? Learning from what we're hearing around across other borders. How do we sustain this work? I'm sure that's a question that all of you are going to have. Having a data infrastructure for research and quality improvement, critical. How do we link primary care with community resources, integrate behavioral health and social determinants, which you've already heard a little bit about this morning, and building partnerships, I think, between various types of researchers, and then transforming practice. What will practice looks like post a patient-centered medical home, post the Affordable Care Act, and post-COVID, I think is a yet unanswered question. Appropriate antibiotic use seems to come up at every conference. And nowadays we're thinking about COVID and testing. And we're thinking about what are going to be the questions of value for the future for you, for the New Jersey PBRN. I think there's lots of potential opportunities there. And if you go to the next slide, Oliver, that's all I got. So if you don't mind, let's just take down the slides, because I really want to have some conversations here and be able to see people. And what I'd like to do, if you don't mind, guys, John Heitzman, can I start with you? And I think maybe a way to start would be just talk a little bit about your organization, and just react a little bit to what you've heard this morning from our other speakers about what you know about PBRNs and what you think maybe are things of value to think about for the future. So John, let me hand it off to you.
Sure. Thanks, Bob, for that great kickoff, and thanks again to the organizers. It's been a great meeting so far. So good morning, everybody. My name is John Heitzman. I'm a family physician by training in Portland, Oregon. And my kind of role here is I'm in leadership at the OCHIN network, which is a nonprofit that supplies Epic electronic medical, a version of Epic electronic medical records to community health centers, and hosts that, not only hosts that, but hosts essentially, it's a cooperative of those centers nationally to do practice improvement among vulnerable patients in care. We have a research operation at OCHIN that is an AHRQ recognized practice-based research network that's been in existence for about 10 years. Worked with Jonathan and Fred at times in the past, and excited to see them as well. Our current some details about our current operation, and then so we have about 30-ish active projects. The OCHIN network has in it about 3 million patients. It touches almost 47 states, but that's a little bit misleading. It's really heavily represented in about 25. And most of those patients, about 60% are under the 100% of the federal poverty level, 50% Medicaid. So it's heavily, obviously, a low income population. And most of our interests and our projects obviously are in that group of people. About a quarter speak Spanish, 35% Hispanic. So that's kind of where we're coming from. Our projects have, or just the other thing to note, I think, is our projects, our interests, because we are a health IT organization, have a definite health IT emphasis. So not only using that data that is linked, so patients have common identifiers, so across the whole network. So it falls into, I think, to that big data category that Bob was just talking about. But obviously, a lot of the interventional work in our network will focus around the electronic health record improvements. I think we all know that electronic health records have been talked about and as they can be the saviors, and they can be the bane of our existence as clinicians. And so entering that deeply emotional space for many of us who do clinical care. But that is our focus, and how we approach that. I think, so that's some details, and I'm happy to answer more questions about the network and our work. I think just some initial reactions, and I'll keep them brief because I want to hear from my colleagues here, obviously. But we have I think we have tried in our work to leverage that our big data strengths, that we have, our informatics strengths, to merge it with a classic PBRN ethos, where we are thinking about and trying to take especially health equity questions, but lots of health services questions, and you utilize, overcome some of the limitations of big data work in the past, where things have stayed at really 30,000 foot level, and take that and make it applicable, make it really practice centered, and that's and I think we've had some successes in that, by which just comes over time with relationships, and a lot of hard work. But that is still difficult to really locate questions and answers in the middle of a clinic day. Is always a challenge that we continue to work hard at. But I think that the point there, though, and I think the point that comes up with practice-based research networks in general, that has been the core of my experience, is that comes down in the end to just relationships over time, working together over time, developing trust over time, continual dialogue, so that we are not just responding to funding priorities, not just responding to what we know can get published, but what really anchor this in the everyday practice, everyday community reality to kind of move the needle. So that's just some initial reactions and where we are, and I'd love to respond to more detail later, but I'll be quiet and let my colleagues.
Terrific. Thanks, John. Great comments. Actually, I particularly identified with the 30,000 foot down to the runway. I mean, that's, bringing it down. I love that as a metaphor. So Fred, can I turn to you next? I mean, in Alliance of Chicago, you guys do some terrific work around HIT, which I think John talked a little about, or other things. Can you talk a little about what you guys do at Alliance, and some of your reflections on what you've heard this morning?
Sure, absolutely. Can you hear me, first of all?
Loud and clear.
Great. That's always the biggest anxiety in these meetings. So yeah, it's really interesting to be talking about PBRNs, because in many ways, PBRN even was something that we taught were involved with as clinical leaders even prior to the founding of Alliance Chicago. In some ways, it framed some of our goals. So we are a health center controlled network similar to OCHIN. Our mission is to improve personal, community, and public health through collaborative innovation. And certainly a big part of what we do is providing access to HIT infrastructure, which includes electronic health records and data analytics, but also have since our founding focused on research. Even our initial EMR implementation was an AHRQ funded research project, thanks to you all. And then last, clinical collaboration. So all kinds of ways that we could leverage tools, both research and health information technology, to actually engage in improving care and outcomes. So it's really interesting to reflect. So first of all, we have a chief research officer, and she's very fond of starting many of her talks with a reference to Semmelweis, who is one of these examples of practice-based research, a surgeon who made the association between hand washing and surgical infections and led to antiseptic techniques. But it is kind of a great reminder and prompt that so many of our great discoveries and insights came from just observations that are that come at the point of care. And I'm such an old guy in these meetings that I remember when PBRNs, the cutting edge technology was to use card studies, where we used a 3x5 card to write down observations or collect observations and assemble them to come to data. So that was a big motivator for us to lean into health information technology. And fast forward now to the point where we, similar to OCHIN, have 3.5 million lives across the country, virtually every health disparity group. And through modern data analytics, now it almost it makes me cry. You could, at the push of a button, like literally within seconds, pose and answer a question. So it's really interesting that now I think the focus to me is at both ends. First of all, it's in the collection of the data. And at that end, there are a couple considerations. One is we as providers, my colleagues are still laboring with producing a note for documentation for medical, legal, and billing purposes or whatever. We really are not viewing that as the opportunity, which is what I dreamed when we started out, of collecting data that's populating a living dynamic database. And actually, it's sad that when we look at the average typical note today, actually a relatively little portion of what's contained in it is up-to-date information that was collected at that. A lot of cut and paste, a lot of automated. So the data quality is an issue, even when we get people to adhere to standards. But the other thing that I think is most interesting, and the reason why we're so passionate about being involved in practice-based research, is what is the database itself? Knowing that the inputs into health are only a small portion of them are medical. And actually, we're making such a big deal now through precision medicine of adding genetics. But even if you add genetics, the majority is still, and I'm so glad Jonathan's on the call today, most of it is from psychosocial, behavioral, environmental factors. And yet, the typical practice guideline doesn't even think about those things. And so this is why, a lot of emphasis on how do we incorporate that data, both from the healthcare setting and external to the healthcare setting into the database that we're working from. And that's, of course, very exciting today because we're standardizing information within our walls. But I think the big opportunity is with trends in interoperability, with the 21st Century Cures Act and the liberation of data, with FHIR, bringing in the ability to have consumers interact with data in their own lives and settings. We're going to have a much richer database. So to me, the challenge now for us as a PBRN, it's not that the technology is a beautiful gift. I think we're still back to how do we begin to sift through and decide what information is important? How do we advocate for our consumers and communities to do that? And how do we pose the most thoughtful and the most impactful questions? Just some random thoughts.
Terrific. Great random thoughts, though, Fred. Love that. And think about actually it's systems and how we use data in systems to make decisions about care. And I think that's, or understand care. That's terrific observations. So Jonathan, actually had a nice segue to you around some of the sort of other issues that need to be addressed when delivering care. Why don't you talk a little about your organization and some of your reactions to what you've heard this morning?
Sure. Thank you, Bob. I want to thank the Rutgers and the NJPBRN for putting this meeting together. I think the timing is absolutely right. The need is here. And I really commend the university for committing to building a statewide practice-based research network and hope we'll find many opportunities to partner together. So I'm Jonathan Tobin. I'm a cardiovascular epidemiologist by training. My day job is running Clinical Directors Network, CDN. And I'll talk in a moment about CDN and Squared. I wear another hat, which is the co-director for community engaged research at the Rockefeller University Center for Clinical and Translational Science, the CTSA grant at Rockefeller. And I'll come back to that because I think CTSAs provide an interesting opportunity for PBRNs that we haven't necessarily spoken about in detail. But CDN got our start really by cloning and borrowing some of the guidance from the Dartmouth Co-op, which is really one of the very first practice-based research networks to come into being. And our first funded project was in collaboration with Dr. Alan Dietrich, and it was a successor to an index card study. And so we had to think about how to transform index cards into punch cards and then punch cards into data files. And so I think a lot of that history is really important because the informatics infrastructure was always a key question. How do we transform data that are routinely captured in clinical settings and turn that into research data, research quality data? And the whole push for real world evidence, which I personally think is a major opportunity for health center controlled networks and practice-based research networks to make amazing contributions to transforming both research and practice. But in a nutshell, CDN takes the opposite view on the translational research question. And we describe this as translating practice into research. And really thinking of this bidirectionally, we like to talk about translating research into practice, but I think it's the recognition that it's the experience of practitioners in usual care settings delivering usual care, whatever that standard of care, that really provides the important framework for understanding how to improve care. And many of our studies look to usual care as the control condition. And as we've all experienced, when we do these studies, suddenly usual care is a little bit unusual because we have to do things to enhance it, but it still contains the elements of what most people are exposed to in their care setting. And so where I think PBRNs have the greatest opportunity to make contributions to transforming both research and healthcare delivery is the notion that the PBRN is the ideal vehicle both to generate new evidence and then to disseminate and implement that evidence into practice-based settings. And I think about really the confluence of several streams that have been either implicitly or explicitly mentioned. So comparative effectiveness research and the related patient-centered outcomes research really provide very important opportunities to test the relative effectiveness of different strategies and to decide what works best for which populations. And the flip side to that is to really begin to think about the implementation science questions in tandem so that we're not first establishing what works and then figuring out how to get this into practice, but really building that translational spectrum from basic science all the way through to population health. And so we need to frame every study in its location. And if we think in a team science perspective, we really ought to be thinking about the other members of the teams that should be included in this in this research. And so this is where I think the CTSAs can potentially play a very important role. And the partnership at Rockefeller and CDN has tried to bring basic scientists directly into healthcare delivery questions so that as we design innovations, basic science innovations, the investigators are really thinking about implementation. We only have to think about the very effective but very difficult to store and to distribute vaccinations for COVID-19 to really wonder whether frontline clinicians in FQHCs and other settings in the United States and even lower resource settings globally, if they had been part of the design team for COVID vaccines, would the rollout have looked different? Would the uptake, both nationally and globally, have looked very differently? So I think the idea of the full spectrum of translational research, of making comparative effectiveness research and implementation science become front and center to this. I'll mention, as Bob did, that we were one of the fortunate programs to be funded under the AHRQ P30 program, and our group is called the N Squared PBRN, the network of networks, and Fred and John have been wonderful partners in this, as have their networks and a number of others, and we've continued to expand. And it really provided an opportunity not only to think about scientific methods, but also to think about business and sustainability, because when you have a lot of partners and fixed budgets, the pieces of the pie get smaller and smaller. So we really had to think about how do we build enduring partnerships that adequately resource projects so we can do the work that needs to be done. I'll mention two other things to sum up that I think the opportunity that PCORI has presented, and in particular PCORNet, which both Fred and John and I we're all involved with different clinical data research networks that I think provide an opportunity to take big data, but without the little data, the information that we can capture at the point of care. I think we have the opportunity to build a hybrid model that combines the best of big data with the best of little data and really try to understand the impact of care. And to do that, we really need to focus on training a cadre of clinician investigators whose career is spent delivering that care, but asking thoughtful questions and participating in those research teams as full participants, as full and equal members, and as leaders. So to sum up, I'm very optimistic and think this meeting has given us a chance to really see the great possibilities that practice-based research offers, and again, grateful to Rutgers and certainly to Bob and his colleagues, David Myers and my former program officer from ARC, Rebecca Roper, for the help that they did in transforming CDN into N².
That's terrific, Jonathan. Thank you. And great remarks from everyone here. And I'm actually starting to see the themes come out, really about data and how do we move data and how do we use it at the point of care practice, but also the relationships piece. So let me just make a quick plea to the audience, because you've got great people here on this panel. Bring those questions in. And if you could keep an eye on the chat for me, that would be helpful. And just wave at me if you see a question that we need to deal with. I'm going to do one more round of the panelists here just to sort of get some follow-up reactions. And then we'd love to start to answer your questions, either in the chat or otherwise. And one thing that I wanted to raise that I know is going to be important for any PBRN that's in its infancy, at least starting out, is really how do you have relationships between sort of the systems and the academics and the basic scientists and the clinicians. And John Heitzman, do you mind if I sort of ask you sort of react about how you've dealt with that at Ocean? How do you bring together sort of different practices, different types of people together to do this work together? Because you talked about relationships a bit. Do you have some reflections on that might be able to help the folks here?
Sure. Yeah, it's a great topic, and I'm not sure if the answer is anything but time and hard work and patience, and but which is what we've tried to do. I think I was really reflecting on Jonathan's comments about kind of the evidence to practice and practice to evidence, and the idea that the ideal of that and the importance of that, and I think the what that often manifests as practically as when you're in a partnership with academics and a community clinician, for instance, the willingness to really, with academicians kind of full of research questions and full of ideas and full of things that they want to do or we want to do in a setting. The willingness to basically unwind those and to really actually completely deconstruct that based on those relationships and that feedback. It's not that those things we should never have those, but to really have a relationship that is truly bi-directional as a starting place. And knowing that, we all run into is a community clinician who's a full-time clinician does not have the time and energy necessarily to supply the entire length of a asking and answering a question, but the willingness of the person who does have that bandwidth to be able to basically really engage in that relationship and make it kind of bi-directional as a starting point. And I think that's the thing, at least at Ocean, we've tried to do and have some success with in projects. And a variety of different kinds of projects, from kind of bigger data projects to smaller work in individual regions or clinics. But it's that willingness to really have your initial research ideas as an academician be kind of deconstructed when they're and let those be redefined by your partners. I think is a piece that helps, at least as a piece of that. So that's one thing.
Yeah, thanks, John. Fred, how about you? Do you want to reflect on that one a little bit? What do you think?
Fred, you're muted.
Double muted. I had to do that before the call was over. Sorry, you all. Hopefully that was the last. So I think I share that innovative collaboration is in our mission statement. So I think I'm going to make this up. Excuse me.
Yeah.
I think there was some kind of commercial for candy where someone was running with chocolate and someone was running with peanut butter, and they came together and there was this chocolate peanut butter thing going on. I think of that when I think about academic researchers and practical clinicians. Like there is a natural a combination there where academic researchers bring this sort of rigor and discipline and scientific way of posing questions, and clinicians are, naturally curious and observant about what they're seeing in daily practice. And so creating that linkage is very rich. And a lot of it has to do, frankly, I think with that sort of chance relationships that develop. I think we started on the strength of very early relationships that existed between us as clinicians and academic researchers at Northwestern. And even prior to the whole electronic records thing, we were putting thoughts together and doing research together. And it just has really mushroomed from there. And I think the huge playground that we now have with the data infrastructure is one in which there's so many opportunities to put those matches together. That's what I'd say. I do think that there's a handicap on the clinician side because there has to be a freeing up of time, even of mental space to do that observation. And I think that's one of the biggest things that healthcare needs to recognize the value of that. My fear, we look at the crisis we have of clinician morale and everything, it's based on people that are so buried in routine day to day that they cannot think anymore. And that's a crisis. So I think I would like to see us all be tackling that. I'm really thrilled that a piece of the equation for us has been deliberately to seek funding to put into the clinical setting to balance that out, to create those opportunities.
Wow, it's a great reflection, Fred. Actually, I can see, that is that's a value of being part of a PBRN is having, if you can find ways to get that opportunity to think and actually get back to enjoying the part that you got into, the reason we got into this. I think that's a terrific observation. Hey, we do have one question in the chat. And Jonathan, I'm gonna actually, you might be the first one to react to it. And it's from Joel, who says, it's my understanding that most PBRNs are primary care based. And can you speak to the potential of including specialty practice in a PBRN? Do you want to take that one on?
Sure. I'd actually love to, because we're in the process of creating a linkage with cardiology and oncology in a new project to really try to address that question for cancer survivors, people undergoing their cancer treatment, and then long-term survivors who are at increased risk of adverse cardiotoxic outcomes from many of the immunotherapies, targeted therapies. So I think that the notion of practice-based research came in large part from the general practitioners in the UK. I think a lot of the antecedent principles came from that idea. And so maybe we have the greatest start, but I think you raise a really critical point, Joel, in that there needs to be a reflection of the way in which care is complex and involves consultations with specialists, handoffs to specialists. Bob, you mentioned to err is human, and most of those errors, or many of those errors, happen at the interface and the handoffs, and where miscommunications occur or lack of communication occurs. So I think one of the challenges that electronic health records, that networks like PCORNet and health information exchanges provide, it becomes that opportunity to improve the handoffs, improve the communication between primary care and specialty care, and improve the opportunities for research. At the same time, those electronic health records are overwhelmingly full of information. And I think, Fred, you made the key point that time is the most valuable challenge that we face. And so creating that time and space both to organize and review the data in the charts and respond to it, I think is both a research challenge and a practice-based challenge. But Joel, I think you're absolutely right. And there are really good examples in emergency medicine, in oncology, and nephrology, where there are practice-based research networks. They may be called clinical research networks, but it's not just the domain of primary care. And I think the future is in collaborative research that includes primary and specialty care networks.
Mm-hmm. Thanks, Jonathan. That's terrific. So actually, we have a couple other questions in the chat, and I'm going to hold off on Steve Peskin's one because I want to save that for a round robin at the very end, because I think that's a really terrific question about areas of focus that you might suggest. But before that, I want to get to Sue Wang's. And Fred, you opened up this topic about creating a space. But John, I'd like to hear you react about this part. For people who are clinical only and don't have protected time, if you had particular techniques or the groups that you work with of how you can help free up some of that that mental space, I think that Fred talked about and Sue Wang is interested in.
Yeah, no, it's great. I think I mean, it comes back to funding, and what we do at Ocean is whenever someone comes to us and wants to work with us, there's this intake form where they are filling out their initial ideas, and on that, and it's phrased in a way to encourage this. Would you like to involve a clinician investigator? Would you like to involve a patient investigator in this? And that is highly encouraged. The idea being, even if it's not something that this project is not a direct, clinic intervention, that basically we would seek out funding for network clinicians to be involved, to try to start to carve out time for them to kind of scratch that scholarly itch. So even my projects, for instance, are often just kind of secondary analysis data projects. And what we try to do is we write clinicians into that funding so they even have time to, if it's 10 or 15%, they have time to just that little bit of time to work with the team to do that and to carve out time. So it's mostly been, our strategy has been making it our MO to all funding opportunities are written in network clinician time to be on that to start to free them up, and that's really the mainstay that we've kind of embraced as far to try to deal with this really real problem.
That's terrific, John. Yeah, Fred, do you want to offer something?
Yeah. I just I think that's really important point, John. In addition to that, I mean, I'm just thoughtful about many practices who are trying to make like some kind of case for why or how to free clinicians up, and I just think the connection between research and quality improvement, or even recruitment and retention, is one that practices often don't recognize, that there actually is a business case for including it in a budget. Great story actually from, I don't know if people are familiar with Mike Raycott, who's credited with hiding in plain sight the algorithms for unrecognized hypertension. Mike's story is fantastic. His institution actually had a program where they had protected money to grant clinicians time and access to data people within their organization if they submitted it was a competitive process, a project that was likely to impact quality and outcomes. And he submitted this idea of looking for unrecognized hypertension, and that's how he was granted the time and that thing came to play. Now, North Shore, where this happened, has obviously had a tremendous return on that investment in terms of their managed care contracts, in terms of, reputationally, all of that. So I think more of that, making that case with leadership within institutions about why taking their own operational money and dedicating just even a small portion of it to clinician time is a really good strategy.
So what I'm hearing is the importance of the commitment of leadership to supporting this work. So there's some messages for the team here. So thank you for that. And actually, so I want to lead to another question here. And actually, Fred, I'm going to ask you to weigh in on this one first, because I was thinking about it when you were talking a little bit too. It's about, how do you see decision support tools within the EMR evolving or transforming as the PBRN primary care research results reach public domain? Because I think you talked about the modern analytics now, you can get stuff immediately, and having that at the point of cares is really critical. Do you mind talking about that? And then I'd like to have the other panelists weigh in too.
Yeah, sure. So first of all, when I think of modern data analytics and predictive modeling and artificial intelligence, there's so much opportunity. I give an example. We did a project where we did a look back over a 10-year period of people who developed diabetes against the diabetes screening guideline. And we discovered that there's a huge number of people who were outside those screening guidelines who developed diabetes. And then we're able to engage data scientists and start to bring in other data sources to kind of say, hey, what was missing in this algorithm? So the ability to enrich our current practice guidelines, our clinical decision support with broader inputs and broader data, and actually import ongoing machine learning and predictive analytics into that is a really exciting development, especially when we try to make the pitch for including social determinants related one. That's one. But the other thing, I just want to shout out to ARC for the Clinic Connect project, the idea of having centralized clinic decision support. I think we're really evolving into an age where we need to like give it up. Clinical decision support is not something that should be done at individual practice level. We should be part of huge networks that are doing that kind of data mining and posing those questions. And then we should be drawing down those clinical decision support artifacts and expressing them within our own records. And the last wish is that that also be extended to thinking about involving consumers in really cutting edge clinical decision support.
That's great. So Jonathan, do you want to weigh in on this one?
Yeah, I'll add to those really important insights that I think there are data streams, again, big data streams out there, Fitbit and the pedometer and smartphones, the possibility of turning that data, those data which are being captured and being used in business and marketing, but turning those into health information and streaming that. I worry about data overload, and we already have issues of reminder fatigue among clinicians. So I think we also really need to invest on individualizing data displays so that clinicians can access the information in a way that's most comfortable for them, but not be overwhelmed with the myriad of data streams and inputs that could be put in front of them. And I think both AI and the kind of practice-based research that tests the clinicians as the research participant to really understand how can they best use that information to make those best decisions. And I agree with Fred that if we could transform the US Preventive Services Task Force and guidelines.gov and all of the work that AHRQ is doing into a stream that goes directly into decision support and electronic records, not leaving it up to every site to try to figure out how to incorporate it, we could really accelerate and shorten that cycle time from research and development into the point of care.
That's great, Jonathan. Thank you. Appreciate you sharing that. Great point.
Can I make a
John, go ahead, John. You want to weigh in?
Just real quick. No,
Please.
Very much agree with my colleagues, and wanted to underscore, I think, just in this topic specifically, the importance of PBRN work, especially, as Fred is referring to, machine learning, artificial intelligence, and those technologies that are just exploding and treated as devices and rolled out. The necessity to test those and the implementation of those in real world settings is so crucial, especially when you're looking at it from a health equity lens and the potential pitfalls that, when we start incorporating social determinants and race and all those things that we can just get into so much, led down so many bad paths. And so the importance of the need to test those things in the real world and in real practice settings to see if they provide meaningful assistance to clinicians and patients and communities. It just underscores the need for networks like this so much in this in this age.
I appreciate that, John. And can I pick on you also for Stephen Schwander's, especially because I was thinking about, you have a lot of data on vulnerable populations, and Stephen was a little concerned about how that data might be abused, and used perhaps in ways that aren't in support of the research enterprise, but really might be used in negative ways or abused. Do you have controls in place that you do to protect your data and how it's used and interpreted? Maybe you just comment on that briefly.
Yeah, sure. It's a great question, and it's something we think about a lot. We just have, we have a relatively strict vetting process. So when folks are wanting to work with our data, they have obviously some administrative things to go through first, but then it basically comes to what we have a steering committee that I serve on as well as some of my colleagues. to review their kind of work in the past, the given project, and to make sure it aligns kind of in with our mission of OCHIN and what we think. So, I mean, obviously, is that foolproof? No, but it gets a pretty hard look, and then has to be approved, obviously, after our recommendation by OCHIN's executive leadership, and then obviously it's subject to all, data use agreements, ethics approval. So we've had good success with that, and we have not. I can't think of an instance in where that has failed, and we've felt like any data has been abused. But that look is very necessary, and I'm sure Fred Alliance probably has similar kind of processes.
Fred, do you want to weigh in on that one at all?
Yeah, just similar to John, I think this is also the role where we look to community advisory boards and their involvement on IFH. It's one of the questions that we always ask. It's like, is there any opportunity that there would be harm? And the other thing, I think, in any community engaged research, is always the community needs to be involved in every stage of research, including dissemination. So that's another checkpoint, that before data is disseminated, consumers have the opportunity, communities have the opportunity to weigh in on how that data is disseminated, what the messages are. It really is, not hours. By hours, I mean narrowly hours. But
that's great. Thanks, Fred. Well, just let me let folks know that we were given permission to run past 11:50 or 50 minutes after the hour by Ann. Thank you. Stephen, I'll try not to run too close to your time at noon. We'll give people enough time to have a bathroom break. But I want to do a little speed dating round here. We had this great question about what key themes, topics, areas of focus would the panel endorse research questions to answer. So I want to hear from everybody. Let's go around and see if you can think of some key themes, topics, or area of focus that you think are particularly important that you want to share with the PBRN community today. So I'm going to start with you, Jonathan. Is that okay? Do you have a couple of things you want to throw out there?
Sure. So I think, since the lens of this discussion is health equity, we need to put that at front and center, and we need to think of that from both a workforce setting, workforce development setting, and the patient engagement setting. So how do we prioritize health equity? How do we ensure active and meaningful participation from the standpoint of clinicians and staff in these settings? Because this is the workforce that's going to do what we're asking them to do. And so they need to derive some personal benefit in terms of professional development and opportunity. And so I think that's, and I think academic medical centers can play a very important role in that, and that should be addressed. Number two, designing studies that follow workflow. So studies that don't slow down the enterprise, because if what we're ultimately about is improving access and quality of care, the last thing we really can afford to do is slow down that process. So I think the idea of designing studies that follow the flow and designing for dissemination. So how do we think about what the results of that study would look like and how it would transform care? So I would put those as the two key themes. And then the other piece of this, from the team science standpoint, we should be thinking about the full translational research spectrum, from the basic science all the way through to population health. And even if the study is addressing one key component of that, the handoffs and the engagement of the antecedent and subsequent teams that are going to do that kind of research really need to be built in. And so, as Fred mentioned, at every point of the process, patients, consumers, the other stakeholders need to be part of this. But I also would encourage the PBRNs to think about working backwards to T2 to T1 to try to build that partnership in basic science, so that those discoveries can be delivered in the kind of care settings that we are concerned about enhancing health equity.
Terrific, Jonathan. Thank you. Great suggestions. John, can I go to you next? Do you have some reflections on key topics or areas of research you might suggest?
Sure. I mean, I think the thing that the general topic that's been on our mind and my mind is what we touched on is the social determinants of health and how we actually use or approach those practically in the care setting. We all know they're important, obviously, but how we kind of approach that data how we use it, how we think about, whether it's communities, whether it's asking patients this information, whether it's community partnerships, whether it's tailoring care, what really is how do we use that data in the real world and practically on a day-to-day basis in the care of patients and kind of in relating to communities. There's still so many questions there about how that works out practically, and that's really probably the thing that I would emphasize right now.
Terrific, John. And Fred, I'll give you last thoughts about what you think some research areas or themes that we could potentially focus on.
Well, great. I get to say ditto to the great priorities that Jonathan and John said. I guess I would also add, one interesting thing that our stakeholders have started to raise with us are studies that look at not like how do you help people who are sick or what makes people sicker, but what is it that keeps people well? So it's an interesting lens, an interesting new frame that we're trying to take in some of the questions that we pose or studies that we take. And then the other area, again, in addition to the ones that were already mentioned, because health equity is, really a critical thing. And by the way, we were also challenged on that one to not just studies that admire the problem, but could we actually pose interventions and test interventions? But the last one is this whole burgeoning of consumer care that's moving out into the consumer realm through consumer device, through mobile devices, through the porting of information to their realm. And I think we need to expand our thinking to be posing, questions or looking at things that pertain to things that are happening in the consumer realm. They spend much more time. We spend much more time outside of a doctor's office than we spend in it.
Terrific. Thank you, Fred. Well, I think I'm going to actually wrap it up here, if that's okay, Anne and Oliver. First, I want to thank the panel. So Jonathan Tobin, John Heitzman, and Fred Rockman. What a pleasure for me to hang out with you guys this morning. I hope our attendees got something out of the discussion. I'll speak for myself and potentially the panel is, we're available if you want to reach out to us in the future to have questions about things. Happy to support your work. I personally look forward to adding the New Jersey PBRN to the ARC's PBRN registry. I think it'll be a great addition to the 169 that we have there already. I think there's really some great thoughts here and some really terrific themes. Thanks to Dr. Don, Oliver, and Ann. Appreciate the invitation, and you enjoy the rest of the meeting. So we'll stop there and turn it back over to you guys.
Thanks so much, everybody.
Thank you so much, guys. This was a wonderful panel. I learned so much from each of you. And I think just the one sentence reflection in the sense that tomorrow, Ray Panettiere, who is the director of our CTSA, will be speaking as well, especially regarding T1, T2 components of the PBRN. Perhaps it's not easy, it's very difficult to do PBRN in general, but not along saying getting to the T1, T2 components into that, but I think it's worthy of effort. During our early vision discussion of the PBRN, we wanted to not only create a PBRN, but take us a little bit outside of our comfort zone as well. And I think also hearing the panel speaking about the subspecialists, helps us as well to think through that. And that was our vision from earlier. Takes people a little bit out of their comfort zone in terms of what a traditional PBRN is. And reminding me of a scenario of a patient that I was taking care of in and out of nursing homes on dialysis with CHF in a span of 7 days, was between hospital and nursing home probably about 2 to 3 times, as well as seeing almost about a dozen different specialists in the process. And if we're only focused on primary care as the components, that we miss a large part of that pie. So I think that transition is really important.